So thank you, Dr. Dulangi, for taking your valuable time to be here with us and talk about today's topic, which is dealing with gender and sexuality issues in general practice. So it is with great privilege I introduce Dr. Dulangi Dahanayake, who is a senior lecturer at the Department of Psychiatry, Faculty of Medicine, Colombo, and an honorary consultant in child and adolescent psychiatry at the Lady Ridgeway Hospital for Children in Colombo. She is involved in capacity building activities related to the field of child and adolescent mental health in Sri Lanka. She has published in peer-reviewed journals and has presented at local and international scientific forums on subjects related to child mental health and mental health of medical undergraduates. Thank you, Dr. Dulangi. Over to you.
Thank you, Dr. Rampi. Can you all hear me and see the screen? I think you're muted, Dr. Rampi.
Yes, sorry. Yes, we can hear you.
All right.
Yes,
Okay.
and yes.
Okay. Good afternoon, everyone. So I've been asked to do a session on dealing with gender and sexuality issues in general practice. So I have had to do a bit of reading around this because I do see a lot of kids and adolescents where there are certain issues, but it's been a bit of a time since I have been seeing adults with sexuality issues, but I was lucky enough to train with Dr. Kapila Ranasinghe, who is a senior consultant psychiatrist, who does have specialized clinics for disorders related to gender and sexuality at NHSL, and we have offered support for lots of patients. So as I discussed with Dr. Eranthi, I thought I'd start off with a few case scenarios where I would like for you to sort of think a bit about what these mean to you and what sort of thing you might do if you see this sort of person in your practice. So all three cases that I'm putting up are ones that I have actually seen. Of course, I have made certain changes so that they will not be identifiable. But all these three are cases that I have actually seen and worked with. Would the audience like to comment on how they might approach a child, a 19-year-old who requests treatment for gender transition? This is someone who has been brought up as a male, but reports that the preferred pronoun is she, and that she wants to be identified as a female, and that she's in a lot of distress due to having to be in the male body, and requests for hormonal treatment for gender transition. So what are the things you might do? Yes? Any thoughts?
Probably want to get a background information about a little bit more about and accept the patient's pronoun.
Yes. Any other things? Any other thoughts?
What were the triggering factors for her?
Yeah, why this current visit? Because she reports that it's been there for a while.
Puberty and other things, sexual characteristic,
Yes.
and whether he's actually female or not in genetic basis, and endocrinological changes.
Yes, we will need to get an idea about the genetic sex and what has happened during the puberty period. So we'll discuss this as we go on. We can refer back, and you can also think of this person when we discuss further. What do you think are the other aspects? So we are thinking of mainly the biological aspects here, the genetic sex, what have the pubertal changes been like? Any other aspects you want to consider when you see someone like this in the general practice?
So, social aspect, social.
Yes, yes. Because
What about what are the bad effects of this mentality happen to education and relationship and those?
yeah,
What is the preferred sex for the relationship of? Is there any homosexual or any other relationship? Sometimes may affect the other childs in the family or society with child abuse because of
yes,
this gender variability, especially in homosexual things can be happen to children and medical legal aspects.
yes. So there could
And
be medical legal aspects. And Ramanathan has said that we need to understand the psychological concerns. So this person says that it's distressing. We would need to assess for the psychological status and what her aspirations are and expectations are from this consultation. And then this is another girl that we have seen. She identifies as female, she's 15, but she says that she's homosexual. And parents are distressed and requesting hypnosis so that we can sort of cure her and make her heterosexual. Sorry, I have missed another message from Sandini, who had said, for the previous case about peer interactions, bullying, or any discrimination that might have happened during the developmental period. Yes, that can also affect how they perceive their gender and sexuality. So here, what can you possibly do? Yes, parental education. What would you tell the parents? It's a 15-year-old girl. So there are also these expectations from hypnosis and changing people, which we will need to address because those are unrealistic expectations. But of course, we'll also need to address the parental distress. And we'll need to see how we can approach the girl. Any thoughts?
She's 15 years old, so is she really sure about her sexuality, or is it a hormonal surge during this time? It's like Dr. Ramanathan is saying, detailed history, examination, look into social aspects, her educational background, her friends association, her school aspects, so all that, probably what kind of social life she prefers, movies, or is she influenced by those kind of activities, or is it a friend who has really, is she really that? Probably that needs to be first addressed.
Yeah. And like Dilshan said, homosexual feelings can be normal for this age. So we'll discuss about how sexual orientation develops, and during the teenage years, the adolescents, they do question their sexual identities and their orientation. And this could be part of that. But what we generally see is now the parents become so distressed and insist that the child becomes heterosexual, and then now these are teenagers, so they are also pretty difficult to deal with. And then they decide that they don't want anyone to judge or decide for them, and they keep on insisting that they are homosexual. So if we try too hard also, that's going to end up with its difficulties. Then this was another person. I saw him for therapy for a long while. That was some years ago. This was a 32-year-old male. So he actually came with a black eye because he had been assaulted by a group of people when he exposed his genitals to female passengers in a bus. Then he was taken to the police and I think assaulted there as well. And he said that he had psychiatric illness and is seeking treatment. And he showed one or two sort of not prescriptions. There were some notes written by a consultant who had seen him in the private sector, and he said that he had a psychiatric illness, and they sort of made him come for therapy. And he also was interested, and he said that he wants to cure himself of this behavior, as he was due to get married in 4 months' time. So he came, he didn't come after his wedding, but he did come closer to the wedding date also. He did come for a session. So how do you think you can support this sort of guy?
Has he done that earlier many times?
Yes.
Exhibition?
Yes. So he was someone who has done it, but this time, unfortunately, he was caught.
But he wants to get rid of it. So maybe that.
Yes. Now I don't think the thing was now he didn't really have a lot of remorse about his victims and all that. The reason why he wanted to get rid of this at this particular point in time was because he was getting married. So these are really challenging situations because without that person having adequate drive or adequate, really wanting to adequate motivation to get away from this behavior or change its behavior, it can be extremely difficult. And on top of this behavior, he also had other behaviors, other sexually deviant behaviors. And I never did meet his fiance, but he said he was going to get married. Sometimes these situations are very challenging, and we may not be able to only manage these in the medical setting. We might also need support from the legal services because now he has had an offense. So those are certain things that we need to think about because there are these other aspects as well. But of course, I think the family can possibly bring such a person to your practice. And another thing that we have seen over time, over the years, several times I have seen young boys, 13, 14-year-olds who are brought by the families because they steal female undergarments from neighboring, neighbors' clotheslines and get into trouble. So that's another the different sexual practice that creates social and legal problems. So when we talk about sexual issues and gender issues, I just wanted to find some clarity in the terminology that we use. So sex is a term that's generally used for characteristics that are biologically defined. So you have your sex chromosomes, the internal and external genitals. And then gender is something that is based on socially constructed features. So gender is something that is more than the biological sex. It's also a social construct where there is a lot of social input in deciding what sort of gender a person is brought up in and what he or she decides his or her gender is. Sexual orientation is a term that is used to describe the that is used in relation to the gender or genders to which a person is typically attracted in a sexual fashion. So it could describe sexual attraction, sexual activity, sexual fantasies. So it's not limited to just having sex. Sometimes what happens is, for example, among prisoners or even in school hostels, there are homosexual contact because of lack of availability of alternative options. Not that these people are exclusively homosexual, but this contact might be there because there is no other outlet for their sexual activity or sexual needs. And then these are again some of the terminology that is used. Why I wanted to highlight this is because now we are bombarded with all sorts of words and terms and different meanings for sexuality and gender and sexual orientation. So I have just put up a few. So if you say bisexuality, there are so many terms that are used to define different types of bisexuality. And then queer covers another whole set of, sexual orientations as well as gender identities. And then we have the different gender identities. So nowadays kids come and tell us that they are not. I mean, previously we used to see the transgender people. So cisgender is used, a term that is used when the gender identity aligns with the birth sex. Transgender is, of course, when they feel that they are not, their gender identity does not align with their biological sex. And then there are the non-binary people who say they are neither male nor female, that they do not fall into this binary gender categories. And then, of course, it comes with a whole lot of other terms, and it becomes really, really confusing. It's so difficult to keep up with all these words. But then, of course, we must try to find out and try and reduce the confusion, because when we see someone, we have to try and see where he or she stands. But sometimes we may not understand the terms that they use, and it's always best to get their clarification, especially when you are seeing adolescents or young adults, because they may use certain words where they actually don't mean what we traditionally think it does. So we might need to clarify about what they exactly mean. And when we talk about sexual development, there are inputs from the biological aspects, the psychological aspects, as well as the social aspects. So, for example, if we think of the biological aspects, we have the chromosomal sex, and these would in turn help differentiate the internal genitals as well as the external genitals. And there is also this thing called brain sex. So the hormones and all that the brain is exposed to, even from the in utero period, can have an effect on the development of sexuality. And then, of course, with puberty, we have the hypothalamus-pituitary-gonadal axis coming into play, and there are lots of changes. And with the changes in the physical changes, including the changes in the appearance and changes in the function of the sexual systems, as well as the hormonal changes, there are different aspects of sexuality that come into play during this pubertal period. And of course, during the adolescent, during the pre-pubertal, pubertal, and post-pubertal periods of adolescence, there are also changes in how the kids think. because their brains are still maturing and there are certain differences. So actually the thinking patterns are qualitatively different from those of adults. And those also impact on their thoughts about gender, sexuality, and their own identification. So these psychological changes, these different ways of thinking can affect how they view gender and sexuality. For example, one thing that we see in adolescent thinking patterns is what we call black and white thinking. So they think that things are either all good or all bad. It's difficult for them to see the in-between or the gray areas. And this very polarized thinking can create difficulties, especially when it comes to controversial areas like rights of sexual minorities and the right to access care and support that children and adolescents will receive. So they feel, sometimes they feel very strongly about getting hormonal treatment to change their gender identity because they think it's their right, and at this age they are very concerned about the individual's rights and respecting people's rights and being how could I say it, being very idealistic. I mean, we do see this in other aspects of social life as well. We see the young adults in the universities out on the roads protesting and protesting for their rights and all. But as they grow older, only a few of these people take to the roads. So these cognitive changes in adolescents would impact on how an adolescent views gender and sexuality. And individual temperament or the style, the personality style of the adolescent and young adult will determine their attitudes towards sexuality, and sometimes, especially if they are very introvert, they may have difficulty in approaching and responding to their sexual needs and their attractions. And during adolescence, the need for intimacy increases. And there have been different, there are lots of theories about adolescent sexuality. And the most famous of which are, one is, of course, the Freudian theories of psychosexual stages. And during adolescence, they are in the genital phase. So they are interested in sexuality and their need to engage in related activities would increase. There was another psychologist named Erikson who described psychosocial stages of development. And he said that during the adolescent period, the teen years, children are trying to identify their identity and their role in life. And one aspect of this identity is their gender and sexual identity. So that is why when we spoke about that 15-year-old girl, so it's a normal phenomena, like one of you mentioned, for children this age to wonder whether they are homosexual or heterosexual. I mean, not all of them would wonder, but a fair proportion would. And then sometimes they would read on it or they would ask people. And especially in our culture with the segregation of boys' schools and girls' schools, sometimes they may even develop certain attraction towards the same-sex individuals simply because of lack of availability to channel their sexual needs. And generally what we see is, like in the case of the girl that was brought to us, the parents become really distressed, and then even more than the parental reaction, we get the teachers reacting to it, saying that, this child is bad, he or she is corrupting the other kids. And then there's a big ha-hoo at school. And these children, because they're adolescents, they are also very sensitive to being judged and being, they hate it when other people tell them what to do. So if the parents say, no, this is a passing phase, you'll get over it, then they'll be more likely to try and stick to the identity or to the thoughts that they are homosexual in orientation, just because they want to show that this is, that they are capable of thinking, that they are not frivolous, that they are not, this is not a fleeting thing. So the best thing in such cases is to listen to them, validate their feelings, and allow them to discover themselves rather than us trying to force things on them. Because especially in schools and as well as with parents, what we see is they become really worked up, and then the kids also feel cornered, and now they can't sort of back down and say that maybe they are not homosexual, because now they've been told so many times they are not homosexual. They want to try and prove that they are, and this creates a lot of tension between kids and their families, as well as even within the child himself or herself. So, but these, the concerns or questioning about their gender and sexuality, these tend to resolve as they come into their early 20s. And sometimes a small percentage may end up being homosexual as well. So we can't say that all the kids who question will become heterosexual, because there is a certain percentage of exclusively homosexually oriented people as well. And then there are lots of social factors that come into play in terms of sexual development. So in relation to the cultural beliefs, there are 3 types of cultures: the restrictive cultures, semi-restrictive cultures, and permissive cultures. In restrictive cultures, there is a lot of segregation of gender. There's like very strong prohibition on premarital sex, and even punishments if someone is found to be pregnant outside of marriage or found to have had premarital sex. And these generally tend to be more restricted towards females in the culture. In semi-restrictive cultures, the prohibitions are still there, but they are not strongly enforced and usually can be evaded. And they can still have premarital sex and get away with it. But if someone falls pregnant, then that creates quite a bit of issues. I guess our culture falls into this semi-restrictive type. And then, of course, there are the permissive cultures where they encourage, expect adolescent sexuality, and even in childhood, they encourage sexual behavior and play. But of course, none of the countries or none of the cultures prevalent today are totally permissive. There are certain restrictions in even the most, permissive like cultures. And then when we think of the social aspects of sexual development, the social influence, of course, there is a lot of influence from parents as well as from their friends. Especially during adolescence, the friends' input becomes very strong, and these kids tend to think about what the friends are doing. So if they promote watching pornographic videos, kids may get together and watch. And if most of his or her friends have girlfriends or boyfriends, then the person will feel left out and feel that they also need to have someone and have sexual contact. There are kids that we see who are concerned because they are not having boyfriends or they are not having sex. These are school-going kids. So they come and say they are not having sex, but all their friends are. And they feel as if, they start to worry whether they are losing out on something or whether they ought to have sex. So all those influences from peers are there. And then, of course, there's also influence from media and the internet. So there's a lot of literature related to sexuality. And if you do see adolescents in your practice, I'm sure you would come across, especially now we are seeing increasing number of adolescents coming and expressing that, they are pansexual or they are gender non-binary, because when we were small, we didn't even know of these aspects, or we never knew that we could be gender non-binary. But now there's a lot of literature and kids read a lot online, and then they start to wonder whether they are also having these tendencies. And social media again has a lot of influence. Like I said, people post about their sexual prowess and having girlfriends and boyfriends, and then the young adults might start feeling left out unless they are engaging in similar activities. So what we discussed is quite, nicely separated sort of thing. However, the development of sexuality is quite complex. And when we talk about eclectic or like a combined model of sexual development, we talk about 3 different strands related to sexual development. One is sexual differentiation and gender identity. Of course, there can be biological, psychological, and social impact on those, in the sexual responsiveness of a person, and the capacity for close dyadic or intimate relationships. And what generally happens is in childhood, these strands are quite separate. And in adolescence, they sort of start to get intermingle, and as they go into adulthood, there's a lot of interaction between these 3 strands and they sort of combine together. So the gender identity, the sexual response, the intimate relationships, it sort of all gets together, and the person identifies their preferred activities in terms of their sexual activities as well as their gender roles and their relationship roles. When we see someone with sexual practice or a concern about their gender, sometimes it can be very difficult to identify whether it's actually normal or abnormal. Because most of these things have been like socio-cultural constructs. For example, the Victorian values, influence of religion, and even Freud and the law back in the mid-20th century rather, was prohibitive of homosexual activity. But now it's decriminalized in most countries. In the West, although in Sri Lanka, I think there's still ongoing debate and news and everything coming up. But these socio-cultural things do come up. That is why we see the 15-year-old girl coming, the mother bringing her saying, she's homosexual and we want her cured because of all these socio-cultural constructs. Even though it has been, identified as a normal behavior and that it's no longer considered a psychiatric disorder, it's no longer considered illegal in majority of countries, and even Sri Lanka, I don't think they sort of take any action, although the law is there. So then we wonder why the parents are still concerned. That is because of the religious and other cultural values that are imparted on us from an early age. And then, of course, some people argue from a biological perspective that, some people say that homosexuality is biologically predetermined and that the person can't help himself or herself. And then there are other schools of thought that say, from an evolutionary perspective, homosexuality does not serve a purpose. So there are lots of debate and confusion. How, as psychiatrists, how we have, how the bodies, the governing bodies, and the diagnostic criteria has been developed is they have looked at the distress and the impact of a certain behavior or certain belief system in order to diagnose this as disorders. So homosexuality itself is no longer considered a disorder, but they may have associated depression and other mental health issues. So then there are those other issues, but when we define a disorder, it has to have a certain degree of distress and impact. That is why we have changed the term gender identity disorder to gender dysphoria in the River classification system, because if we say gender identity disorder, then it inherently sort of means that not identifying with the assigned gender is a disorder. So being transgender is a disorder, which is not the norm anymore. So now what we say is being transgender and being distressed because of that, because in the current gender role they are distressed, so there is dysphoria. So we address that associated mental health impact rather than the person's identity. Any questions so far? before we move on to briefly talk about the disorder? Yeah, I'll move on to the disorders then. So there are the disorders of sexual preference. So for ease, we have divided these disorders, but like I said before, also there are certain overlaps. But the disorders of sexuality and gender are divided mainly into three components: disorders of sexual preference, disorders of sexual function or other sexual dysfunctions, and gender dysphoria. So like I said before, it's no longer termed gender identity disorder, it's gender dysphoria, because the person's right to identify himself or herself as being in any gender is respected, but if there is associated distress or depression or mood issues, then we term that as gender dysphoria. Homosexuality, like I said, is no longer considered an illness or a crime. And what studies have shown is that at least 3% of the population are unambiguously homosexual. And that 3% go through a period of bisexuality, of which for the majority, it is a transient period. But there's a fair number of people who do identify as bisexual as well. And like I mentioned before, we need to be aware about the developmental of sexual identity during adolescence, especially if you are, brought an adolescent saying that they are homosexual. And then the socio-cultural norms and opportunities also come into play, because in certain cultures, there are lots of restrictions and segregations of the sexes where people might engage in same-sex behavior without actually being homosexual. So, for example, in the prisons and even in the armed forces, there is homosexual contact because of lack of sexual partners. Not that these people have no homosexual fantasies, but there are no outlets for their sexual needs, and sometimes then they engage in sexual activities with the same sex. So just because someone has had sex with someone of the same sex does not mean that that person is of homosexual orientation. And then when we are talking about sexual orientation, we cannot, not talk about the Kinsey scale. Have any of you heard of the Kinsey studies? If you are interested in human sexuality, I would suggest for you to read up a bit about the Kinsey studies. Anyone who has heard of Kinsey, Alfred Kinsey? So he wrote 2 books about, his sexuality in the male and then, of course, the female. So those were, I think, published in the late 1940s, early 1950s, at which time the societies were very restrictive of, different sexual practices, and talking about sex was taboo. And he had a lot of opposition, and there was a lot of controversy around his methodology, because, there were lots of concerns. But those were landmark studies, and they paved the way for further studies, because then people started talking about sexuality, gender, and then, of course, there were also other developments in the medical field, such as contraceptive pill coming into use in the 1960s. So with all those, the revolution of, the taboo subject of sexuality gained a lot of prominence. And Kinsey describes sexual attractions and behaviors on a continuum. Rather than saying someone is exclusively heterosexual or homosexual, he developed this thing called the Kinsey scale. So rather than heterosexuality and homosexuality being a dichotomy, there was a lot of in-between behaviors as well. So if you search for the Kinsey scale online, you find that it describes from one end there the exclusively heterosexual, then you have the exclusively homosexual, then the bisexual, and then the person who occasionally engages in homosexual activity but mainly identifies as heterosexual. So it's a continuum rather than being a dichotomy. And like I mentioned before, homosexuality is not considered a disorder and we do not offer treatment for it anymore. However, like for our girl that came with, believing that she's homosexual, they may need psychoeducation, especially parents will need a lot of support, and children may also need support and practical help. And sometimes they may also have associated depressive disorder, which would need treatment. And the other thing that I generally tell the parents is, a 15-year-old girl, whatever the orientation she identifies with, is highly unlikely to have actually engage in sexual acts in our culture and in our settings, especially if they are going to an all-girls exam. There's a lot of, the teachers are vigilant, the parents are vigilant. Sometimes if we start worrying and pressing them too much, then we might create even worse problems. So I just wanted to put homosexuality there because still people do come to us asking for cure, but like I said, we do not consider that as an illness anymore, but we do support people for their associated distress. And then we have the disorders of sexual preference, also termed paraphilias. They can be divided into two main groups: anomalous activity preference and anomalous target preference. So if I were to elaborate that a bit more, now the first one, the initial ones are actually anomalous activity preference. We have the voyeuristic disorder. So these people, someone to, for us to term it as voyeuristic disorder, this should be the predominant sort of means of sexual gratification, and it should be a repeated pattern of behavior. So it's not one or four, sometimes we see young adolescents peeping in and looking at girls changing their clothes because they're curious. They have not had the opportunity to, actually view a female body. So like a one-off event or, a few scattered events doesn't mean that there is a voyeuristic disorder. But if it's a persistent pattern, then and if it's the main source of sexual gratification, then of course that's a problem because it does have an adverse impact. So when we think about our criteria for distress and impact, it does have an adverse impact on the victims. And the same goes to exhibitionistic disorder. So these are anomalous activity preferences. Then of course, frotteuristic disorder, I'm sure many people in this audience would also have had difficult experiences in buses where people, touch and rub without the consent of the other person. So that again is a disorder because there is a lot of impact and distress. Then sexual masochism disorder, where they being humiliated, beaten, or made to suffer. It's a primary means of gaining sexual gratification. Then there's sexual sadism. And then there are also abnormal target preferences, especially the pedophilic disorder. So that carries a lot of medical legal weight because we are talking about sexual activity with prepubescent children. And then fetishistic disorders, where they use non-living objects and non-genital body parts as primary means of they are engaging in sexual gratification. Then there is also something called the transvestic disorder, where cross-dressing creates sexual gratification and sexual arousal. So there are also like a whole lot of other paraphilias, but these are the main ones that have been identified. And here, when we are thinking of management, I think the most important aspect is risk management. So if an exhibitionist is brought to you by the police or by his relatives, or even if he comes on his own, we have to always explore the risks. For example, this 32-year-old that I was seeing, so there are two types of exhibitions. One type actually are very, socially inadequate. They don't have social skills. They are very shy. And they may sometimes even expose a flaccid penis, and they might feel very embarrassed afterwards or guilty. Not embarrassed, they feel guilty afterwards. But then there's another group who have antisocial tendencies, who expose a fully erect penis and who don't have any remorse. So the person that I described initially, the 32-year-old, is actually one of these people. So he carried a lot of risk because he was quite antisocial and there were aggressive tendencies. And he would, scare his victims by exposing an erect penis. And especially in the case of pedophiles, that's another very sensitive and very an area that we have to be very vigilant about. Then, of course, for these disorders, psychotherapy are offered, but in our setting, the access is, of course, not that great. And we do also offer pharmacotherapy, things like SSRI, synthetic steroid analogs, and GnRH analogs. So what these generally do is reduce the sex drive. So especially for pedophiles and all, there is a tendency to use medications in order to reduce their sex drives, especially if they are repeated offenders. And rehabilitation is also an important aspect with counseling, education, and skills training. So these are some of the disorders of sexual preference. Then we also have sexual dysfunction. That's another group of disorders where there is impaired or unsatisfying sexual enjoyment or performance. So they may be divided into disorders of sexual desire, sexual arousal disorders, disorders of orgasm, and painful disorders. Sometimes as general practitioners, the families might be very close to you and they might feel much more comfortable coming and talking to you about their sexual dysfunctions rather than going to a trained psychiatrist or other mental health professional, because they have known you and they may feel comfortable with you and trust you. So in that case, you might come across these sort of disorders. And the other large sort of group of disorders when you think about gender and sexual disorders is gender dysphoria. So this refers to the distress that may accompany the incongruence between one's experienced or expressed gender and the assigned gender. So this assigned gender may be assigned at birth and assigned by society. So the person feels that it's not his or her gender. So I have worked in a gender dysphoria clinic, and these people really do suffer because they feel that they just don't feel comfortable in their physical body because they feel that they belong to the opposite sex. So if any one of you is interested, I would refer you, I would request you to read the Standards of Care for the Health of Transgender and Gender Diverse People. This is available free online, and it is a publication by the World Professional Association for Transgender Health. So there are lots of debates going on about how best to support transgender people or people who have gender dysphoria and gender diversity. Because it's just not the biological aspects, but also the social and psychological aspects that need to be looked into. And then it creates a lot of controversy and uncertainty about how best to approach. And the main components of managing gender dysphoria include counseling and psychotherapy, depending on the severity of the distress. And these people who want to transition need to go through a real life experience in the preferred gender role. So they have to assume the preferred gender role and live in that role. In some countries, they request it has to be for 1 year. In some, it has to be for 2 years. And during this time, gender affirming hormone therapy may also be offered. So sometimes in certain countries, especially if the children, if the pre-pubertal children express gender, that they gender non-conformity, then they may be offered hormonal therapy to suppress puberty, and but they will not be offered any irreversible surgeries. So the gender confirming surgeries, they will of course need to wait until they are legally adults. So in Sri Lanka also, we do offer gender affirming hormone therapy as well as gender confirming surgery. So sex reassignment surgeries are done at NHSL as well. But of course, it has to go through a certain process where they are assessed by different psychiatrists or psychologists, and they live in this gender role. Then they go through hormonal therapy, and they have to, and they should be ideally free of other major psychiatric illnesses that would impact on their judgment. And in the standards of care from the World Association that I described before, they have mentioned that general health and well-being of transgender people should also be treated as for other people within the primary care settings. And there is an increasing, this is very interesting because when I was reading it, I thought it's important for me to mention this to general practitioners, because in countries such as Canada, the USA, and even Australia, the gender transition specific care, such as gender affirming hormone therapy, are actually offered by primary care physicians as well. So they, because of the waiting list for specialized services or the lack of resources in specialized services, trained primary healthcare physicians can offer gender affirming hormone therapy, and sometimes there is like a shared care model with specialized services where the primary care physician is the one who actually continues the treatment. That has been suggested from the specialized care. Okay, so shall we go back to our case scenario and see whether you can think of anything in addition to what you mentioned when we started off? Anything else you think you might now want to consider when you are managing or coaching this person? I do hope I'm audible.
Yes, you are.
Okay, all right. Sometimes when the audience is silent, you're not sure whether they can actually hear you.
No, we have.
Okay, thanks. So I have just listed out some things that we need to do. I think the most important role that we play is as people who listen and validate these feelings, because most of these people, when they come to you and say, they are not female, now they want to be female, our tendency, or from our cultural and social experiences, what we tend to initially offer is we try to help them overcome this. We try to tell them, maybe you need to wait and see whether you will change your mind. And so this sort of thing is actually, we are judging and we are not being very supportive, because then the person will obviously drop you and go to some other general practitioner or other healthcare provider, because we are not providing the support that they need in terms of their mental health difficulties. So we might need to listen to them, validate their feelings, and sometimes these people have an increased risk to self, and there's also a risk of being exploited by other people, especially with all these online platforms and all. There's a lot of exploitation going around, especially for the younger adults or the adolescents. then we need to assess for underlying psychiatric disorder, because sometimes people come and tell us all sorts of things because they are psychotic. Then we need to treat that separately. So we can explore what the child has already, the 19-year-old boy has, or girl rather, has already gone for therapy, or whether they have received any support, and then get collateral information, maybe talk to the family, see what their views are like. We might need to support the family a lot. And we might need to refer for further assessment, especially if they feel that they want gender affirming hormone therapy or gender reassignment surgery, because now they're 19, so legally they are able to request those things. So we will need to refer to specialized services in order to support them. And I think Yasika has also mentioned that we need to discuss the possibilities about, sometimes their expectations for gender transition are, like Yasika mentioned, they can be really, way high, because say for example, if in a male to female transition, so they will do, pedectomy and remove the penis, and they will fashion a vagina and all that. However, then there are limits to their fertility and ability to conceive, and because some of these people, they think that modern medicine is so marvelous that they can actually turn someone into a female and even become pregnant, and they are the child. And because now these people did not have the internal genitalia, so we have to try and see what the expectations are. Because if we also say yes, we can go for monotherapy and start off, and it doesn't come out as they expect, then things are going to be a bit of a mess. And for this girl, anything else you want to do apart from what you have already done? Any thoughts? I think the most important thing is that we understand the normal development, that during this period they might question their sexuality, and of course we need to understand how an adolescent would react to us. They're generally very opinionated and very they are very sensitive to slights. So we have to be extremely careful when we approach this sort of situation, because we don't want to make it worse. But in saying that, we also need to talk to the child, see what her views are, and we have to show respect and validate her feelings. And there might be certain concerns that the child might be having, and especially in this sort of situation, there again might be risk to self as well as risk of exploitation. And we need to assess for any underlying disorders, and we have to encourage age-appropriate behavior. So this is a 15-year-old. She's not going to go around having sex at this age. So she's from a stable family environment, going to school, doing well in school. So it's not like she's going to go around having sexual partners. So we have to, take the spotlight away from this, intense concern about homosexuality that is there in the parents as well as in the child, and make sure that the child does age-appropriate activities, sports, extracurricular activities, studies, so that there is no adverse impact on her development. And then this person, the 32, sorry, I have put 28, the 32-year-old male, anything else that came up, that you think might be helpful? This is, of course, a very challenging case. He dropped out of treatment because, maybe about a few months before he got married, he actually brought his ex-girlfriend, saying that, he has had all sorts of sexual contact with this lady, and he was upset because she was refusing to marry anyone else. So he actually said that he wanted me to talk to her about, getting her to marry someone else. So I was a bit, you know, not at all comfortable with that request, because this was not my patient, and I'm not there as an advising person. I'm there to do a specific job. So I had to keep and stick to my boundaries, and he sort of got annoyed with me and didn't turn up after that. So that didn't end too well. But here there's a lot of risk to others. So we should see how we can reduce his um, risky behaviors and try more, appropriate behaviors. And he does need ongoing psychological support. And I mean, if he continues to reoffend, he might even need to go into a treatment program. But unfortunately, those are not very streamlined in our country, and we are quite divorced from our legal system. The police doesn't have internet, the health services, so it's very difficult to get that coordinated approach to care which such a person would need, because he wasn't really that motivated. It was just because that his wedding was coming up, and he was a bit worried that if he continued to show off his genitalia in public places, he might accidentally do that to one of his future wife's relatives who might turn up at the wedding. So that was one of his concerns, which I don't know. So he wasn't remorseful or thinking that he should change his behavior. So what I mainly wanted to highlight today was that these are really complex constructs. Yes. So Dinshan had said with the first case, the request for gender change, can there be a biological component as well, hormonal imbalance? So we need to investigate it too. Well, generally, if the pubertal changes have occurred, if there are secondary sexual characteristics, if periods are normal, we wouldn't really, try and explore those concerns. But sometimes if there is an ambiguity about her external genitalia, or she has not gone through puberty, then we might need to explore and see actually whether, there was some ambiguity around sex assignment even at birth. So these are really complex constructs. There's no simple answer, because we are talking about living people with lots of different ideas, and nowadays it's all the more complicated because people have much greater access to information. There's a lot more information exchange than before. So this sharing of knowledge among the adolescents, the young adults, this creates a lot of complexity in terms of human sexuality and gender. And it's important that we try and improve our knowledge and skills on those, because otherwise it's sometimes difficult to support these patients. And I mean, sometimes we will have to say that we don't know about something that the person is talking about and ask for further clarifications. So it's helpful, because sometimes we may have a different understanding of some terminology as opposed to the other person, and that can create misunderstanding and difficulty. And the other thing is, of course, we should try to not impose our values and judgment during our professional contacts. We may feel that homosexuality is a sin, or our religion may believe that you have to be in your assigned gender, or that paraphilic behaviors are sinful, but that is separate from our professional contact. So we have to follow the guidelines and the professional behaviors that have been set out to us, and we do not have the right to impose our judgment, because I have seen situations where kids are brought to us and they have seen other people previously who have told them that they are it's not normal, that they need to change, and it creates even more problems for these adolescents than young adults. And we will, of course, sometimes offer further care in general practice settings, and sometimes mostly we will need to support them because they are familiar with general practitioners, and it will be helpful. And they will also need referral as needed. So at the moment, where we can refer is to actually the psychiatric services that are there in the nearest district hospital or base hospital setting, not district hospital, the base hospital setting. And of course, there are certain people who have specialized clinics for people with sexuality and gender issues, but those are rare and quite few. So like I said, the access to care is going to be a problem, and it will, I guess, continue to do so. Yeah, so well, I guess the hour was decided because we thought everyone would be free to join, I think. That's an interesting question of you, Hanker. Okay. All right, so any questions or anything anyone wants to comment?
Thank you so much, Dr. Dulangi, for that excellent and intellectual presentation. And yes, very sorry about the 7 o'clock that I was not aware of. I probably most of our general practitioners are having their practices and finishes by 8. We should next time make it around 8 or 8:30. But thank you so much. Any questions? I actually have one, Dr. Dulangi. Is there a hotline or some helpline for such individuals with these concerns, that because the availability and the accessibility beyond us sometimes it's difficult when we need a specialist opinion? Is there anything that, is there something like that?
Yeah, I think the best option would be to call the helpline of the National Institute of Mental Health, 1926, which is a toll-free hotline. Okay. And there are trained nurses who sort of, it's a 24-hour helpline, so people call, and there will be support available, and further information will be provided there. They also have a chat line. I'm just trying to remember the number of my head, but if you go to the National Institute of Mental Health, go to the web page, you'll be able to find that information. There's also a chat line which we have promoted for adolescents because they feel more comfortable chatting online rather than giving a call.
Okay. We have a question.
Yes, so this transgender controversy in sports, yeah, that is something that is a controversy in psychiatry as well, because the people who are all for transgender rights would say that a biological male who has now transitioned into a female has the right to participate in the same teams with females. But then, of course, biologically there are certain differences which will create a problem for the the biological females who are there. So it's not, it might in one aspect it's not fair by the transgender person because now she identifies as female, but then on the other hand it's not fair for the other females who are running the race because they do not have that genetic advantage because they have been born XX. So there are certain changes, physical changes that are there and advantages. So there is ongoing controversy, like if someone is asked not to participate in a sport with females, then there would be a big how about the transgender rights, and then the other parents would feel that their girls are being discriminated because there is someone else running that race. It's still, there is no firm consensus on those things, but these are emerging issues because increasingly people are using gender affirming hormone therapy, even in adolescents, increasingly in other countries. So there's no yes or no answer for that, unfortunately.
Mm.
And then I think when we started off about the transgender person, the 19-year-old who said, he identifies as a female, someone mentioned about, the sexual and sexual needs, and if she says with the males whether there will be homosexual activity and exploitation. Well, that again is a very complex construct because um, someone who identifies as a female might say they are homosexual if they are attracted to females, although they are, genetically male. So then there's a whole lot of other confusion and controversy there as well. Because I remember once in the clinic we used to support this man. So it was a female to male transition, but he has fully transitioned and was, we have had top surgery and all those things. But like I said, that's why we need to address the expectations of gender affirming surgeries, because it's almost impossible to create a functional or like a functionally normal penis. So this female to male transgender person who identifies as a male now was in a relationship, a fairly stable relationship with a female. So I actually asked Dr. Kapil Ranasinghe what the partner's sexual orientation was, because it was quite confusing for me. And he said that, these are all quite complex and there's no simple answer for that. Because now this female to male transgender person did not have a penis, so he was using a prosthesis and all. And that other person was a genetically female person who was in this sexual and intimate relationship with this person. So it becomes really complex sometimes. And like I said, there's no one answer for these things.
Do they ever go back to their decision? Was you like have you ever come across patients after surgery and hormone therapy, they think, oh, I have made a mistake, I should have been this instead of that?
Fortunately, I haven't had to deal with that situation, but that does happen. So that's why it's important that we stick to the guidelines and we try to, we make sure that they live in the gender role and then they go through all these gender affirming surgeries, because the surgeries are irreversible.
Yes.
And then once you do a oophorectomy and remove the penis, then you can't really reverse that, or even for top surgery for that matter. So it has to be made. So they have to have assessments from 2 psychiatrists and have lived in the gender role, and they need to be told specifically. And there's a lot of especially in the other country, there's a lot of paperwork and a lot of information giving and discussions involved as well.
Yes.
But there are like situations where they do want to revert back, and especially if there are lots of personality issues, then we have to be careful.
What is the prevalence like in Sri Lanka? Is it rising?
It's very unclear, because the thing is we don't have good enough prevalence data. But then it's more talked about nowadays than before. People are more open about it.
Yes.
So it's very difficult to decide whether it's an actual rise or whether people are talking more about it than before, so they are coming out more. Or whether, especially with the adolescents, there is this phenomenon of trying to fit in and be special. So sometimes we see a lot of adolescents, especially like in adolescence, a big part of identity is that, they have some special skill or ability. Like some kids excel in sports or music or studies, but when this identity is a bit, not that strong, then people might start saying that they have gender issues and gender identity problems, because that becomes part of their unique identity also. So there are all sorts of trends, and there's peer influence, and those trends may also come up. It's very difficult to comment whether it's actually rising or not because of these other complex issues. Plus, we haven't had the baseline data.
Any more questions? So thank you very much, Dr. Dulangi Dahanayake, again, once again. Definitely, you have enlightened us on a sensitive but very important topic. Thank you so much. And I also take the opportunity to thank our President, Dr. D.K.D. Matthew, Chairperson, Dr. Dineshani, and our CPD team of the College of General Practitioners. And thank you all the participants as well. Thank you once again.
Thank you. Good night.
Good night.
Thank you. Good night.
Good night.